So for last 3 days, it has been, great academic discussion I heard and I saw in your WhatsApp, and I think Fourier and Odyssey must have been discussed many times, and I will be taking you through some cases and like crux of Fourier and Odyssey, and something about VLP vaccine. So let me begin with a patient which I and this patient came with chest pain
Your
for
voice
last
is
6 months. He
cracking.
was a young. Hello. Yeah,
Your voice is
he was a young gentleman, 35-year-old male, was non-diabetic, non-hypertensive, and he had severe angina for last 6 months, and which was getting worsened for last 2 weeks. His father and grandfather had died of cardiac arrest in their early age, and he was a smoker. And his ECG showed some changes in lateral leads, but the ejection fraction was normal. And you can appreciate a tendon xanthoma in his ankle, and on he was carrying a lipid profile report of 21st February 2019, which was showing a LDL of 315, HDL of 66, TG of 248, and total cholesterol of 436, and VLDL of 55. So clinically, the patient belonged to FH criteria, and if the diagnosis of FH was made, and we did the angiogram as the patient was highly symptomatic, and it was a very significant and critical triple vessel disease. You can appreciate here, entire vessels, LAD, circumflex, diagonal, RCA were diseased. You see the long lesion, LAD, circumflex, multiple occlusions, and RCA, proximal, distal. And we advised the patient to go for bypass surgery. And since he was only 35, he was not willing to go for it, and he insisted for a PTCA to be performed on him. And I went for PTCA and I fixed the lesions by 5 long stents. You see the LAD, the first stent going on, then second stent is the proximal LAD, and the circumflex, the proximal stent, and then overlapping second stent is circumflex. So 4 stents in the left circulation. You can appreciate the result now. This is the post dilatation, and this is the result of the left circulation, LAD, circumflex now fixed, and then RC there is one more stent. So the patient was given 5 stents, and he became asymptomatic, and we gave him started patient on 420 milligram of Repatha. In fact, the patient had a medicine store of his own, so there was no problem in convincing him, and he started taking 420 milligram Repatha. We gave option of both twice monthly or once monthly injection, and he started with the highest dose of Repatha monthly injections. And you see, we started on 16th May, and 15th June, the LDL was 44, and it was an incredible result. And I felt so happy. The patient was doing well. His LDL was 44, and now probably the patient is in a safer side. So this is how we get to see these patients, very sick patients. They come with very bad family history, and if we become lax only by doing a bypass surgery or PTCA without being given proper cholesterol medicines and reducing the cholesterol less than 55, we are not doing justice to the patient. Which we all know, and we have got Japanese and then Lip clinic network criteria. So the patient belong to that, and this is how we differentiate between homozygous and heterozygous. We see a LDL of around more than 400, 450 in homozygous, and they become symptomatic earlier in their second and third decade only. But heterozygous, they become symptomatic in their third and fourth decade, and the LDL level mostly hovers around 190, 200, and more than something around that, there, 200 to 300. If we treat these patients with statin, then we have to add molecules like ezetimibe and possibly PCSK9 inhibitors, which are there in guidelines as well. So we have to reduce the LDL something around less than 55, and it is not possible with oral medicine. And the understanding of lowering LDL and achieving better results started coming after IMPROVE IT trial, and then finally a GLAGO trial gave an idea that as lower as you go to up to 20, you are going to get benefit. And Fourier trial came on just after Glagau trial, and it was a wonderful trial which changed the landscape of treatment of entire dyslipidemia. It was a very large trial, 27,000 patients, and those patients were very high-risk patients. All the patients had either prior MI, stroke, or PAD with additional CV risk factors. So you can imagine the risk status of these patients. They were screened, they were given statins, and then after run-in period, they were given either evolocumab 140 milligram twice a monthly or 420 milligram every month as compared to placebo on top of standard of care. And everyone knows now in this portal there is significant 59% reduction in LDL cholesterol, and the primary events, the primary endpoints, CV death, MI, stroke, unstable angina, or coronary revascularization. Mind you, I be mindful of that. I am emphasizing here of coronary revascularization. The next trial which we are going to discuss, Odyssey, it was not there. So this trial included coronary revascularization also, and there was a 15% relative risk reduction. Total mortality, there was a lower trend, but there was no significant difference. So when we talk about mortality, it is difficult to judge mortality in 2 years or 2.5 years. The patients, they're bound to live longer, and the mortality will be more apparent when follow this patient more than 5 years, 6 years, 10 years. And NNT of the benefit of treatment was 66. And look at this data; it's very, very compelling and surprising, as well as very reassuring. That you see when we hover around LDL of 70 to 90, as in Fourier, we were having a hazard ratio of 0.9. When the LDL was from 50 to 70, the hazard ratio was 0.87, and when the LDL was 20 to 50, it was 0.75, and when it came down to less than 20, the hazard ratio was 0.67. So we were playing with 0.67 hazard ratio, so more something around half of the risk. So it's a really terrific benefit with the PCSK9 inhibitor, and more so the subgroups of recent MI, less than 2-year MI, PAD, peripheral arterial, those patients who are symptomatic PAD, history of stroke, diabetic patients, they did outstandingly great. So NNT of 66 was in entire population, but in diabetes it was 31, and for PAD it was 21. So it makes sense. We have to go all out aggressive on these patients. Then came on the heels of Fourier came the Odyssey trial, and it was aliricumab post-ACS patients within 1 year, from 1 month to 12 months. And basically their idea was to keep an LDL between 25 to 50. So what they did was, if the LDL came down to less than 15, they used to stop aliricumab for some time, and if the LDL was less than 25, they used to half the dose. So they were not going all out with this strategy. They were trying to fix it between 25 to 50. And even with this strategy, you can see here, the results were outstanding, and it was absolutely matching with Fourier. And this was the primary efficacy endpoints, MACE, with P of 0.0003. So very significant, with MACE indicating CHD death, non-fatal MI, ischemic stroke, or unstable angina requiring hospitalization. Primary efficacy endpoints except CHD death, all other parameters were significantly lower. So MACE was 0.0003p. Ischemic stroke, non-fatal MI, and stable angina were also significantly lesser with PCSK9 inhibitor reduction. And all-cause death, you see, the longer you follow these patients up, you will get this benefit of all-cause death apparent. So at 3 years, after 3 years, 4 years, you can see a P of 0.026, a significant reduction, and more so if the LDL is hovering around 100 at baseline, or more than 100, the significant the benefit were even marked. So these were the subgroup with baseline of LDL cholesterol more than 100 in Odyssey, and you can see outstanding hazard ratio of 0.76 for MACE, 0.72 for CHD death, 0.69 for CV death, and all-cause death of 0.71. So any intervention with hazard ratio of less than 0.7, it's really outstanding. So conclusions from Odyssey was made that aliricumab reduced MACE, MI, and ischemic stroke, and was associated with a lower rate of all-cause death. And best part of PCSK9, which we all know and appreciate, is its less side effects, just like local rashes, and there is absolutely just like placebo. You don't have to worry about the side effects, and that is what giving this drug edge over all other strategies. So and these all findings have been aptly incorporated in 2019 ESC guideline, where from lower to better, now we are going lowest is best. So from LDL reduction to LDL elimination, rather we are going, and then for very high risk patients, we have to target something like less than 55. So having discussed PCSK9, familial hypercholesterolemia, where patients clinically, sick patients with bad cardiovascular outcome, post stroke patients getting so much benefit with PCSK9. There have been some studies with drugs like not of monoclonal antibodies, but something which can go and silence the expression of PCSK9, that is inclisiran. And just a little while back, I think SN Roy was talking about inclisiran, and indeed it has shown promise. And there has been trials like Orient 10, Orient 11, which in which they have shown benefit in the at par as with PCSK9, and hopefully they claim that the cost will be less. But at the same time, we have to be a little bit skeptical about the side effects, which was seen in 11% of total population, although major side effects were less. But still, we await the clearance, we await the multi-center trial, and and things are not quite clear with inclisiran right now. To have this, maybe 1 or 2 years, we'll get to know about the fate of this molecule. But it looks promising. Now coming to vaccines, why about giving monoclonal antibodies from outside? Why can't we give some antigen with adjuvant which generates antibodies against PCSK9 or CETP or ApoB100 or oxidized LDL? And this is the targets of vaccine, similar of like what we see in hypertension against angiotensin 2. We are getting some vaccine development. On the same trend, there have been work on vaccine, and this you can see a lot of targets. There are not 1, 2, 3, 4. Multiple targets have been discussed and studied in animal trials till now. And the one which looks more promising is virus-like peptide. Virus-like peptide-based vaccine targeting PCSK9. And I will not go in detail because the outcome is not very clear, and human trials are still awaiting. In the mice, you can appreciate the reduction of total cholesterol, LDL, very significantly, more than 50%. And you can see the PCSK9, free level of PCSK9 going drastically low. So maybe in future this vaccine can be there with us in 1 or 2 years, and likely we are moving towards weekly to monthly injections of monoclonal antibodies or receptor silencers like inclisiran or vaccines in future. Thank you so much.